speak to you all about research, QI, and also EBP projects, because it's something that all of us in medical practice and medical care are involved in. So just a few definitions first. Evidence-based practice. Essentially, this is something that has been codified. You can see a couple of quotes there from different sources. And that really means that based on clinical trials, data, patterns of care, that you're really providing the best type of patient care for the patient based on what is known and what the state of the art is. A quality improvement program or initiative is essentially a recognition by an organization that there is a specific process or outcomes that are not considered adequate or sufficient, and that you want to improve performance on those. And so again, this can be a large variety of different things, and I'll give some examples a little bit later on in the talk exactly what I'm talking about. And then research is sort of a systematic investigation. It can be literally from idea or concept through design, bench testing, preclinical studies, in vitro studies, clinical trials, ultimately with the idea that you're trying to develop, in the case of medical care, a new drug, a new device, a new process to improve patient outcomes. But of course, research can also have absolutely nothing to do with patient care. It can be in any of a number of different types of scientific realms.
Dr. Curley, I hate to interrupt you, but we don't see.
One of my favorite by Professor Einstein. Clearly the reason to do research is to find novel information, do something better to take care of our patients. And this just shows you kind of the key differences between evidence-based practice, quality improvement programs, and research. The intent, obviously, with an EBP is that you want benefits for your patients, for your staff, for your organization. You really want to make sure you're applying standards that are considered the highest possible, and that you're really trying to fit the needs of your patient population. The quality improvement initiative, again, the people who are going to benefit will be your patients, your staff, your organization. But here you've identified a need or a deficiency that you need to improve or should improve on to kind of bring you up to the highest standard of care. And again, you really want to address a specific problem. Research is a little bit more ethereal in that, it can benefit a lot of people, certainly investigators, clinicians. And in the realm of clinical research, when we are testing new drugs, new devices, new products, our hope is that our patients are going to have better outcomes as a result. And again, the idea behind research, however, is even if you don't develop a new drug that does what you want it to do, you still contributed knowledge and you're still finding information that can be helpful. Again, in terms of methodology, for an EBP, you're looking at indicators that will allow validation of your results. You want to include the attitudes and behaviors and practices of your clinicians, your other employees in the hospital. You're looking at the outcomes. With a QI project, again, your measures are a little bit more linear and a little more concrete. If you say you want to reduce your infection rate in patients with Foley catheters, you have a starting number, you have an end number. Those are very easy parameters to measure. In research, these are very complex measures. They require statistical analysis. And research projects are the longest of all of these. Kind of an evidence-based practice review or a QI program can be done in a matter of weeks or months. Some research programs, including one I'll share today, can take well over a decade, if not more than that. In terms of design, I gave you a few examples there of some of the EBPs that are used. I'll show you a rather complex slide I don't really expect anybody to remember, of the Iowa model, which is commonly employed. For QI, again, a large number there. Some of you may be familiar with some of these terms, the PDCA, the PDSA, Lean, Six Sigma. These are all things that are used by organizations like Christus, like Christus Trinity Mother Francis. And then for research, you have quantitative or qualitative programs. Quantitative includes things like randomized control trials, retrospective reviews of results, prospective reviews of results, or qualitative data is more, gee, I've noticed that this certain thing happens and I'm just reporting it so that we can then perform a more quantitative study on it. Here's an example of the Iowa model for evidence-based improvement. You can see pretty complicated. And again, I show this just as an example. You know, this usually requires a committee of people to come together in an institution and say, you know, we want to make sure that the way we're handling something in whatever program it is, I'll use myself in surgical oncology. So for us, we want to make sure that we're using state-of-the-art imaging and diagnostic studies for patients with malignant disease. So we intermittently will go through and review our imaging, talk to our radiologists, make sure that we're getting the right information in reports, and again, be sure that we're providing the information we need to make sure we're providing the best possible care and diagnosis of patients with cancer. Again, in terms of design, you can see that research, as I stated, you have to be patient. It's usually going to take time, oftentimes, as I said, years to kind of proceed from an idea to actual results and reporting of those results. For an EBP, it's usually based on how complicated the program is. You saw from that Iowa design that it can be a pretty complicated process, often takes several months to gather the data, review it, come out with a report. QI is usually fairly quick, a matter of weeks to months. It doesn't require as large a sample size. It can be done in a department or an institution. So statistics, I mentioned statistics. So I already showed you Einstein. Now I'm going to give you my favorite quotes from another guy I like a whole lot, Mark Twain. I love the first one, lies, damn lies, and statistics. Statistics have been known to mislead people in research. So just because somebody says something is statistically significant, don't accept it as de facto. Well, that means it's got to be important and therefore it works. There's been some very well done reviews of scientific literature and clinical trials results that show that fully a third of the reported clinical trials, even in major journals, the statistical methods were flawed. So it is important that you look at these things rigorously, and this is something that I always review when I'm looking at a paper with new results. Again, back to design, doesn't take much time or resources for an EBP or for a QI. Data collection for research is highly codified, particularly if you're getting any federal money to support your research from the NIH, the DoD, DARPA, people like that. You have certain rules on how you maintain the data, how you secure the data, how you make sure that the data is controlled, that nobody can access it or in any way get access to patient information, et cetera. So the data analysis is extremely difficult with research programs. Regulating bodies for an EBP, this is something that's done on an organizational level. So we could do it here at the hospital, or this could be something that Christus could come down and say, we want to make sure we're all practicing in this one specific realm based on best evidence-based practice. QI, again, Joint Commission looks at QI programs and CMS looks at QI programs. So if they come in and recognize that, say, you've got too high a postoperative wound infection rate, they're going to look at that. They're going to want to know what you're going to do about that. Research, you've got a whole long list of regulating bodies. You've got your Institutional Review Board, you've got HHS, nationally, you've got the FDA, you've got the NIH. This is bound by state and national laws. So you've really got to be very, very certain that you're kind of crossing your T's and dotting your I's with those programs. The burdens or risks, if you're talking about patient care, obviously with an EBP, you're trying to make sure that you're providing the state-of-the-art care for your patient. And if you're just looking at saying, are we doing things the way that is current state of the practice, current state of the art, then obviously patients should benefit, should have improved outcomes. Now, if you start saying, well, gee, the state of the art is this brand new treatment that hasn't yet been FDA approved, then you have to do a clinical trial. So that flips you over into the research category. So, there may have been some exciting new results pointed out for a new drug to treat cancer that patients who previously were not doing very well are now doing really well and they're living much longer, but that's not yet FDA approved. Well, you want to be in on that. And so that's where you then engage your clinical research staff and actually do a research trial and participate in the clinical research being done. QI, again, you're trying to provide benefit for your patient population. You're trying to reduce risks and burdens to the patients. You're trying to address a problem that you have identified within your structure or organization or in outcomes of a specific measure for your patients. In terms of who do you share this information with? Well, obviously, if you're doing either a QI program or a best practices program, you're going to share that within your organization, the outcomes of the committee or the group that met to look at that. Sometimes you can publish that at a meeting or present it at a meeting if it's a kind of a novel approach. If you've come up with a brand new, say, you invented a catheter that has a lower result of infection for either central lines or for Foley catheters, that's something you can present. Research here, you have to present within the organization, you should be presenting at meetings, and you should be publishing it in peer-reviewed journals to get validation that other experts have reviewed your research, find that it was well done, find that the techniques and the results are important and worthwhile, and should be shared with the scientific community and ultimately the public. So just to put this into simplified terms, a best practices program, you're really trying to change your practice. You're really doing a constant review saying, we're in a rapid changing medical environment, new devices, new treatments, new drugs come online all the time at a rate that's hard to keep up with. We want to make sure we are keeping up and we want to make sure our practice reflects that. In a QI program, again, you've identified a specific area or, you may have had a site visit from JCHO and they say, hey, your central line infection rate is too high. You need to do something about that. So you then do a QI program. And then again, research is really a little bit more idealistic. You're really just trying to generate new knowledge. And if it happens to that it helps other human beings, great. But you may be doing research that has nothing to do with patient care, but you're still trying to generate new information. So here's some examples of some projects that are sort of best practice projects. That's looking at things like how do we position patients in the OR, who are going to be lying and anesthetized in the same position sometimes for 4, 6, 8, even longer. You want to make sure they don't have nerve injury or pressure ulcers. So what are the best practices on how to do that? Post-op mobilization to prevent pneumonia and to prevent problems with deep venous thrombosis. Pre-medication, making sure that you're really following the current known practices, how to medicate a patient to prevent chemotherapy-induced nausea and vomiting. And then the same with pre-medication for anesthesia-induced nausea and vomiting. All of these current programs came out of best practices reviews. QI examples, again, reducing things like CLABSIs or CAUTIs, reducing the time it takes between a practitioner writing an order for an antibiotic or some other medicine and the patient receiving it. You may say, gee, our patient satisfaction scores on this one unit or one floor are not good. You talk to the patients, you get together, you talk to your staff, here's what we need to do to communicate better, and you come up with a quality improvement program. Again, this is one we've all heard about. We write discharge orders. We need to get patients in and out of the hospital. So how do we do that better? And then, after any procedure or hospitalization or major surgical procedure, how can we reduce the hospital length of stay? Clinical research examples, and again, here I'm specifically using clinical research. Now the state of the art for almost all breast cancer patients, unless they present with very small stage 1 disease, is to do chemotherapy before surgery. This is completely different than when I trained as a surgical resident a little more than 30 years ago, where patients went to surgery first, usually had their breast removed, and then got chemotherapy as appropriate. Again, there's been nice studies that looked at laparoscopic versus open colon cancer resection, showed that patients who were in the hospital a little bit less after a laparoscopic and returned to work earlier. And then there's also studies and kind of a big population base showing how socioeconomic status can really impact infant mortality rates, cancer screening and detection rates, and cancer and heart-related mortality rates. So then we can then say, well, how do we as a system address those inequities? So I'm going to take you back to high school biology or chemistry or physics class. Hopefully all of you took at least one of those things. So with a research program, and this is what I'm going to spend the rest of my time talking about, you start with a question and say, okay, I've got this observation or I've got this idea. And then you do a little background reading on that, and you go and pull the literature on it, and sometimes you find out somebody's already addressed the question. If they have not, then you start with a hypothesis, and then you perform experiments to either prove or disprove that. You analyze your data, and the data is going to do one of two things. It's either going to validate your hypothesis and say you were correct, and you've now created new data and new information that could be generalized and shared, or you find out you were completely wrong. Your hypothesis was incorrect, so you reject that hypothesis and realize, back to the starting board, I have to come up with something else. So here's a question I asked back in 2006. Can hyperthermia, heat, be used to improve the treatment of pancreatic adenocarcinoma, particularly pancreatic ductal adenocarcinoma, which I'm sorry to say still has a mortality rate of greater than 95% in this day and age. It has not improved in over 40 years. So hyperthermia does have a history of being used to treat cancer, just so you know. The Edwin Smith papyri that are 5,000 years old showed that Egyptians were pouring hot oils on things like breast tumors or what probably sounds like skin cancers on the leg or the body. You can imagine how much fun that was, having boiling hot oil poured on your breast or your skin. Tumor cautery was used to treat cancer types. Electrocautery, when that became available, was used to fulgurate tumors in the rectum, the vagina, on the skin, on the breast. Cryoablation, microwave ablation, etc. And it's known that cancer cells are actually much more sensitive to heat compared to normal cells. Here's a completely inaccurate Dutch woodcut that's about 400 years old. You will notice that there is a surgeon there and a man sitting quite calmly on the bench while the surgeon takes a red hot iron from the fire burning at his feet and applies it to a tumor on his leg. You also see pictures of the different irons that were used based on the type of tumor and where it was located, including the round one there at the bottom that was described as for treating anal cancers. You can imagine there were probably 5 or 6 people holding this guy down, because this is in the days before there was anesthesia. So my hypothesis and my research group's hypothesis was we could develop a non-invasive electromagnetic field, combine it with targeted nanoparticles to destroy pancreatic cancers. Here's an example of the field generator that we had. What you see here is a radio frequency generator, and you have an end fire antenna that creates a standing wave electromagnetic field. We have a table here where we could put cells or a small animal or even a large animal on to treat a tumor. So this is a non-invasive way to treat cancer. We looked at a number of different types of nanoparticles. This is something called a fullerene or carbon-60. This is something that chemists at Rice University won the Nobel Prize for in 1991. This is a 1 nanometer diameter particle. It is very tiny. Again, for those of you who don't understand nanometer, if you take one of your hairs off your head and pluck it, it is about 75,000 nanometers in diameter. So you could take 75,000 of these guys and line them up end to end, and that'd be about the same diameter as one of your hairs. So these are very tiny, but they're really cool in terms they have some interesting chemical properties and physical properties, and we know they'll heat because they're very polar molecules, and we can functionalize them by adding side groups that we can add targeting agents to. We also knew we could use gold nanoparticles because they're metallic. They are also known to be non-toxic to mammalian and human cells. And again, there's ways you can add chemical targeting groups to the gold nanoparticles. So this just shows an example if we wanted to show heating. So we could put our gold nanoparticles here in a little quartz cuvette, put it in the middle of our field. And as you can see, at a very low dose, just 36 parts per million, we were producing temperature elevations in a matter of seconds. Just to give you a comparison, so you can see here an over 50-degree centigrade rise in temperature here in about 8 seconds. So in other words, we could put these nanoparticles in water and put them in there and bring it to a boil in about a third of the time that you could do the same with your cup of coffee or tea if you put it in your microwave. Okay, well, that's cool. It's kind of parlor tricks. And so we showed, okay, great. You can put these nanoparticles in a little quartz cuvette and they'll heat really fast, but who cares? All right, well, can you use it to treat cancer is a better question. So here what we did is we took cell lines growing in culture. So this is not in an animal. You've got 2 pancreatic cancer cell lines. You've got a colon cancer cell line, and here a breast cancer cell line. The breast cancer is a control. It does not overexpress epidermal growth factor receptor. So what this showed is that these other cell lines did express epidermal growth factor receptor, and we have a monoclonal antibody called cetuximab that is already used in clinical oncology to target cancer cells that overexpress this particular receptor. So this shows you an electron micrograph of, here's a pancreatic cancer cell that we just added gold nanoparticles into the solution. And we were able to find every now and then a cell that had a little tiny cluster of gold nanoparticles in it, not much. Now, here is a similar cell, pancreatic cancer, that had a non-specific antibody. So not cetuximab, but an antibody that didn't bind to anything. And once again, you see almost no gold in the cell. On the other hand, if we took the gold nanoparticles and attached them to cetuximab, you can see here all kinds of black in the cell. And actually, when we went to higher magnification, the cell was just packed with gold nanoparticles. And we showed that the cells continued to grow and divide. The gold nanoparticles being there did not kill the cells. They didn't cause the cells to vary their behavior at all. And this just shows a really nice close-up view. Here you can see the gold nanoparticles actually binding at the cell surface where that receptor is, and then actually being endocytosed and taken into the cell. And like I said, you see gold nanoparticles all over the place in this. So we then took our pancreatic cancer cells that had been treated with gold just in the solution, a non-specific antibody in gold, and then a specific targeted antibody in gold. And lo and behold, when we treated them in the non-invasive field, we were able to completely kill the cancer cells at a very low dose of gold. And if we actually put in an antibody that blocked the receptor first, we completely blocked this antibody specific uptake. So we proved that it was the antibody attached gold that was attaching to the cancer cells and getting into the cancer cells. And then when we treated with the field, we were killing the cancer cells. And this just shows very nice what happens. So again, here's a cancer cell, pancreatic cancer cell, a lot of gold nanoparticles in it, but it hadn't been treated with RF. Cell is alive, normal structures. Here's one after RF. You'll notice that there's literally stuff leaking out of the cell membrane. The entire internal architecture has been destroyed and disrupted. That is a dead cell. So again, here we're just showing another technique that with the cetuximab, you can actually see that it does bind to these pancreatic cancer cells. When we add the cetuximab with gold nanoparticles, you can see actually it does still bind, but interestingly enough, when you add the gold nanoparticles, more of the antibody gets taken into the cell, which is kind of an interesting phenomenon we had not expected. And we realized that was because the cell was recognizing the gold nanoparticle as something foreign and was internalizing it. All right, well, that's great. So now we've done what literally thousands, if not millions of investigators have done, which is to kill cancer cells growing in a dish. We can do that all day long, but that doesn't help us with a walking, talking human being. So now we had to do it in animals. So we did that. So these are mice that are growing pancreatic cancers in the pancreas. And the important thing to see here is this is the growth curve of the tumor. So if you treat mice with the radiofrequency alone, doesn't kill the cancer. If you treat it with the targeted gold nanoparticle alone, doesn't kill the cancer. But if you treat it with the gold nanoparticle and then follow it with a radiofrequency treatment, most of the animals live for several weeks. And we actually had some that were cured that ended up living, their entire life, about 2 years for a mouse. So we were able to completely destroy the malignant tumors in some of these animals. We also showed that with some of those other molecules I mentioned to you, the fullerenes, that they are unique in that they actually get into the nucleus of cells, which we were really excited about, because that means we can drag chemotherapy drugs in that bind to the nucleus, things like 5-FU or gemcitabine, platinums, other drugs that are known to act in the nucleus. And we actually showed that with gemcitabine, we could get about a 10-fold increase of gemcitabine levels in the nucleus of pancreatic cancer cells by using these fullerenes as something to kind of bring them into the nucleus. So this is a method where we're using the nanoparticle actually as a drug delivery vector as well to improve the delivery of this, and then combining it with the radiofrequency field. So this shows an animal model, and here that we put the tumor in the flank of the mouse. And this just again shows you that if you just treat a tumor with just the RF alone, you don't get much heating. And this is live cancer here. Whereas if you inject in those carbon fullerene nanoparticles and then treat with the RF field, and this is a thermal image, you can see there the tumor getting hot. And here is the microscopic view. This is bleeding into the tumor. These are inflammatory cells. This is normal tissue here. This again is a dead and dying tumor. So we were able to show successful treatment with this technique. We also showed that these things produce something called autophagy, meaning if you add these nanoparticles and then do the low-grade thermal treatment, that you actually cause the cell to start digesting itself. And so that was also a novel finding. So it turns out that these nanoparticles combined with heat shut down things like mitochondria and other things in the cell and cause problems. And again, this just shows that if you treat pancreatic cancer cells with this combination of nanoparticles and heat, you can get a lot into the cell, and then the cells are actually dying. You're seeing here the nuclei are falling apart. These cells are being killed in a matter of just days by this non-invasive technique. And this shows the same thing with an immunofluorescence assay, again, just showing that we use gemcitabine that we brought in with the carbon nanoparticles plus radiofrequency field treatment, and you start seeing that these cells are less and less viable and that they're essentially undergoing autophagy. The red here shows that these cells are essentially destroying themselves from within. They're just sort of releasing enzymes within the cell, and they become dead and dying cells very rapidly. So we know that RF field was able to produce this even without nanoparticles. That also surprised us. So we found that cancer cells are specific to different frequencies. So if you have pancreas cancer versus liver cancer versus colon cancer versus breast versus ovarian, turns out every type of cancer has specific frequencies they respond to. So we were able to use that to treat animals with different types of cancer with pulsed radiofrequency fields. and essentially improve the treatment with standard chemotherapy drugs or other drugs. So this is yet another direction that we ended up going with this project, sort of showing that with research projects, you sometimes get findings that were unexpected and that didn't necessarily go along with your initial hypothesis. So you then revise your hypothesis and go, hey, we got an added benefit here. So one of the things that we did as a secondary hypothesis, and as a matter of fact, is that we realized that the RF fields can increase blood flow within a tumor. And you may or may not realize this, but tumors obviously have a lot of abnormal blood supply. One of the treatments we use for certain cancers is a drug called bevacizumab, which is a drug that binds to vascular endothelial growth factor and kind of prevents the cancer from growing new blood vessels. But by itself, that slows tumors down, but doesn't really kill them very well. Well, we know that tumors are cells that are growing too rapidly. And interestingly enough, they actually oftentimes have reduced blood flow compared to the normal tissue around it. And that's because they're growing so fast that they have increased pressure within the tumors, and they have abnormal vessels that are easy to compress. And so sometimes, even though you've got drugs that are really active against the tumor, if they're not getting into the tumor, you're not helping. So this shows a movie. So the red is a tumor. We've stained the tumor red. This is actually a pancreatic cancer. And here you can see the blood vessels. We use a blue albumin dye. This is real time. So what you're seeing here is we've started treating this animal with this pancreatic tumor with radiofrequency, and you're starting to see more blue in the tumor. So again, there's no tricks here. This is not time-lapse photography. Now I'm going to take you to this one. Here we've subtracted the red color. So again, this is just done with the computer. It's even more dramatic here. So again, what you're seeing with the movement there is the heartbeat of the animal. That's why you're seeing it twitch like that. And you'll see that as soon as we start the RF field, these are not blood vessels growing in. These are blood vessels that are already in the tumor. They are just collapsed and compressed by the increased pressure within the tumor. And what we now know, and what we were able to prove in further experiments, is the radiofrequency essentially increases the arterial pressure in the small vessels around the tumor and sort of opens up some of those mechanisms and increases the flow into the tumor. So what we were able to show with this is this non-invasive RF field allowed us to increase the delivery of drugs or agents that were capable of producing an immune response, even immune cells like CD4 and CD8 cells, which are the types of cells that actually can kill cancer cells. We could get a 10-fold increase in those cells. So where are we at in our scientific method? So we've published a whole bunch of papers about this. This is continuing to ongo. At this time, this research is continuing by my group in Houston. We hope to begin early phase human trials in the next year or two with this to treat pancreas and liver cancer. And again, I'll go back to the very beginning. This is 2021, right? This project started in 2006. So here we are 15 years later, from idea to building a device to testing it to actually hopefully using it to treat patients and improve their outcomes. So the interface of research, evidence-based practice, and a quality improvement program. I'll give you the example of CLABSIs. So this is a problem. Patients, if they get a central line infection, they can get septic, they can have all sorts of complications, they can even die. So is there anything we can do with the catheters that are used to reduce the infection rates? A colleague of mine, when I was in Houston, asked this question, and he went to a chemist friend of his at the University of Houston, and they started coating the central lines with different antibiotics. So their hypothesis was an antibiotic-coated central line would reduce CLABSI rates. They took a whole bunch of different materials, literally tested almost every antibiotic you can imagine, and came up with both the materials and the antibiotics that seemed to work the best using animal trials that took about 6 years to perform. multiple antibiotics reduce the infection rates, it appears that chlorhexidine silver sulfadiazine was the best. So that's what's currently used. These catheters are now routinely available. Interestingly, though, in 2018, a meta-analysis failed to confirm lower CLABSI rates with this. So this led to an EBP review to question the routine use of these catheters. So this just goes to show you that you may come up with a hypothesis, experiments that support your hypothesis, and it initially looks good, but you always have to go back and check, recheck. So now it's thought in further studies that despite this meta-analysis, the antibiotic-coated catheters do slightly reduce the risk of infection. So they are still commonly used. And so what's important is this led to QI programs that showed that routine and rigorous changing of central line dressings actually reduced the CLABSI rates even more than the antibiotic catheters. So here's where the idea of a cool thing, an antibiotic coated catheter, great idea, helps a little bit, but better is just good quality nursing care and human interaction with the patients to make sure that things are being followed and performed correctly. So in conclusion, what I would tell you is you need to continue to question the way we do things. If you have an idea, if you notice something you think patients' outcomes or a specific problem is not being addressed, you have to decide, do we need to do an evidence-based practice review? Do we need to do a quality improvement initiative? Or is this really something that's just not known? We don't have a known way to improve this patient outcome, in which case you generate a hypothesis. You've got to hunker down for a long haul if you do that. I've told you, projects I've been involved in have often taken decades to come to fruition. And once again, there's no such thing as a bad result. All you can do is either validate or repudiate your hypothesis, and you still can report the results and provide information. And the important thing is I just encourage all of you to stay active in research and question at all times. And the most important thing I can leave you with is always question dogma, because when we become dogmatic and set in our ways, that's when we become most dangerous. I think it's critical that we always remember to be open to new ideas and new ways of looking at things so that we can improve the outcomes of our patients. And it's a lot of fun to do research and to do projects that allow improved outcomes for our patients. So with that, I will thank you for the invitation to speak. And I believe I've actually allowed time for questions. So I will stop sharing my screen and be happy to take, and I see there's some chat questions. So let me look at those. There's mostly comments that you couldn't see my screen, but then you could. Okay. So I will be happy to answer any questions anybody may have.
At this point, if you just want to unmute yourself and ask him the question directly, you can, instead of putting them in the chat if you'd like.
Yeah, I'm good with that. I'm better at talking than typing. So I know I talked about some kind of high-end wacky stuff there, including nanotechnology and electromagnetic fields. Again, I use that specifically as a research example just to show you how we do things in the world of medical science and developing new treatments and new processes. So while it can take a long time, it can still be a lot of fun because you can find lots of things that can be helpful to our patients.
All right, well, if we don't have any questions, then we will let Dr. Curley go and everybody gain a little bit back of their day. We want to thank Dr. Curley again for speaking. That was an awesome presentation. If you'll notice on the screen, there are 2 QR codes. The one on the left is for physicians and APPs. The one on the right is for nursing and other disciplines. If you will hover over it with your camera on your phone, it will take you directly to it. If you have any questions, you can email myself or Gary. And with that, hope everybody has a great weekend. Thank you again,
Okay.
Dr. Curley.
Very welcome. Happy to help. Everybody be safe.
Thank you.